Let's do
Hello
that.
and welcome to our new series, Memorable Cases. We're here to have open and honest conversations about life in plastic surgery and also to learn from each other's experiences, good and bad.
Each time we will be joined by two senior plastic surgeons who will share two cases each, cases that shaped their careers, one inspirational and one that didn't go as intended. I'm Rebecca Shirley.
And I'm James KK Chan.
So to kick off this series, we're delighted to be joined by two expert breast reconstructive surgeons based in the UK, Mike Tyler and Martin Jones.
So before we get started, perhaps we can ask the both of you to tell us a little bit about yourselves and also maybe something we don't know about you already. So in fact, I think I first met you, Mike, when I was your SHO back in 2007. And I'm proud to say that we're now consultant colleagues with Rebecca at Stoke Mandeville. So I know you a little bit, but please, can you say a few words about yourself for the audience?
Hi, so my name's Mike Tyler, and thank you for that introduction, James. Yeah, I'm a consultant at Stoke Mandeville. I did the same training program as you, James, the Oxford Stoke Mandeville. I didn't actually end up in Salisbury training program. I was appointed consultant in 2001. I started doing DEPs and breast reconstruction in 2003. I sort of took over that service, and obviously now 20 years later, I've got a fair few under my belt. What do you know about me? Well, things that you might not know, James, is I like to write poetry. So on the wall behind me, I've got some of my poems written, and I can always recite one to you at some point in time, but maybe not on this webinar.
Thank you. And Martin?
So Martin, I just wanted to say that while we were planning this, we realised that the year that Mike met James was the same year that I was training under you in East Grinstead, which was 2007. So yeah, if you can say a few things about yourself, perhaps that we don't already know, that would be great.
So yeah, I was appointed at East Grinstead in 2006. So I've been a consultant plastic surgeon now for 17 years. I did the Pantems training scheme, so I went through Mount Vernon, Royal Free, and then down to East Grinstead, and decided I wanted to do hands. So I went off to Australia to do a hand fellowship, and then realised actually probably breast would be the place that I do most microsurgery. So ended up doing quite a bit of microsurgery with people like John Pereira and Roger Smith down at East Grinstead. So carried on when they departed. So I've been a consultant, as I say, for 17 years. And the reason why I ended up in plastic surgery was thanks to Brent Tanner. He came to our school. I grew up locally, 3 miles away from this hospital that I work at now. And he came to talk to us about plastic surgery. I thought, that is what I want to do. So I went to medical school knowing I wanted to be a plastic surgeon, believe it or not. So yeah, that's me.
Any other little tidbit to rival Mike's poetry writing?
Probably my electronic drum kit in the man shed down the bottom of the garden would drown out his poetry. But we'll have...
Yeah.
Excellent. Right. So thank you. So I think, Mike, you're going to start.
Sure. Okay. So I perhaps didn't quite get the brief just as well as Martin. Martin listens to instructions much better than me, and so my talk's slightly more general than a good case and a bad case. But the first thing I wanted to sort of share because with you is this case. This case here. So I'm in the clinic, and is that showing, by the way, guys?
Yeah.
Yeah. So I'm in the clinic, and this lady comes in, and she's had a bilateral nipple-sparing subcutaneous mastectomy and immediate reconstruction with a pedicle tram flap in 1990. And what kind of struck me of a few things was that in 1990, just after I'd qualified, that would have been an absolute, leading operation. That would have been the state-of-the-art breast reconstruction. And she came to see me. And as you can see, there are a number of problems. Obviously, the problem with the bilateral pedicle tram flap is you destroy the anterior musculature. You can see that the breast reconstructions are herniating through the pedicle down the hole that you make for the pedicle, the tube you make for the pedicle. She hadn't been able to wear a bra she had a very, very odd motion, sort of getting onto the examination couch, because of course, you know, she had no rectus muscles, so she had to turn to one side to use her lateral obliques and everything, and had spent the last 30 years doing that. And it was very difficult to know what to do. I couldn't really help with her tummy. We had this conversation, and the reason why I'm showing you this is because literally, I think it was about 2 patients later on the same day, this lady came in, and she had had almost the same operation. In fact, we had removed, she'd got a tumor on her right hand side, so we'd done a nipple removing skin sparing mastectomy, and that's a reconstructed nipple. And then we'd done a risk reducing mastectomy on the other side, because she was I think a BRCA carrier, or certainly a high risk patient. And what it kind of just struck me, what I was seeing in that clinic were the advances that, you know, plastic surgery is made in 30 years. And you can see from a tummy, this lady was fully active, doing her yoga, her sit-ups and everything else, whereas the other lady had spent 30 years, you know, with this really odd motion. And I just felt that this was a really good case to put to the listeners here. You know, that's a fantastic advancement, and of course it's been done. I remember I was around when DIEPs first started coming in. I remember John Pereira, who you mentioned earlier, Martin, sort of standing up at BAPRAS. I think he was just an SR, saying, look, DIEPs are where it's at, and if you're not doing DIEPs, then you shouldn't be doing reconstruction. Or fairly forthright. I may have misquoted him, but it was fairly obvious. And I remember, like you, I was a hand surgeon and a burn surgeon, and then the breast surgeons asked me, look, can you come and do this? And I remember thinking, right, if I'm going to do this, having, you know, done all the pedicle trams as a registrar and seen all the fat necrosis and all this kind of stuff, I thought, if I'm going to do this, then I'm going to do DIEPs. And so we started in 2003. So yeah, guys, keep on pushing the envelopes, and actually in the end, you know, you were doing this. This lady's going to hopefully live a completely normal life, but minus her breast tissue. So that was really the first case that I wanted to put to you guys. And I'm going to stop my share for the how do we stop share? There we go. So yeah, so really that was my first success story, if you see what I mean, and that's a success for the whole of the plastic surgery community, and all the endeavors that all that work of those giants on whose shoulders you know, we're standing, and what it's done for our patients.
Great, Martin.
Let me just share my screen and then I'll start. So I want to present a case where I aged for about 10 years in 24 hours, and I hopefully snatched victory out of the jaws of defeat. This lady was referred for basically reconstruction. She had left-sided breast cancer back in 2012, neoadjuvant chemo, had 2 wide local excisions which had incomplete margins, and then it was a new unit who didn't really refer to East Grinstead, and it was a new consultant. So we wanted to get it right for obviously the person involved, and also forge close ties with this unit. So I ended up doing an immediate DIEP. This was her initial picture with 2 wide local excisions on the left-hand side. So day 1, took her to theatre. The CT scan that we used showed that there was quite a high single perforator on the right-hand side, but a supraumbilical one on the left. So we could only use the one on the right, really. And it went fairly well. She was in recovery by 4 o'clock in the afternoon. And we had a microfellow and a registrar, and they both participated in the operation. slight change in colour at 10 o'clock with the SHO going to see. So called the registrar, who called me, and then within the hour, literally 15 minutes from me being called, we managed to get her back into theatre. And what I'd done at the time of surgery was use one of the vena comitants, and the other one was really quite patulous. And so we didn't get down to the confluence. We just used one vena comitant, it was about half the abdomen. Clearly it wasn't enough. When the blood pressure came up, it became venously congested. So I decided to try and use a small repair by taking out the clot in the patulous vein, did a venotomy, released the clamp, and it flowed through distally once I took the clamp off the end of the patulous vein. So I then swung that round and put it onto a side branch of the connected vena comitants, and everything was good. We went and had a coffee for half an hour, went back, and it was normal. The capillary refill was 2 seconds. So she went to recovery. I went to bed, got my beauty sleep, and then at 6:35 in the morning, the SHO was called again, and I was called at 6:50. Managed to get it back to theatre at almost 8:30. I cancelled my private clinic, and this time, again, venous congestion. There was a clot of 4 centimetres in that patulous vein. The smaller vena comitans was working, but not enough to offload the affected flap. So I elected to do a cephalic turn down. I was with quite a bright-eyed, bushy-tailed micro fellow that day. His name's Adam Blackburn, and he's one of our brilliant colleagues at Queen Vic. And we raised the cephalic turn down. I had to derotate rotate the flap anti-clockwise by about 100 degrees to get the dilated superficial vein near to the cephalic turn down. All was well. Back into recovery. Missed my private clinic. Had to move people into the evening. Went to have a bit of a lie down. Got called to recovery. So this is the 4th episode in 2 days, and we spoke to the patient. I really didn't want to take her back to theatre under a general anaesthetic in 2 days. And actually, there were no theatres available. There was a big trauma case in the trauma theatre, and everyone was, there's no anaesthetist available. So Adam convinced me in a rather youthful way to take a micro set round to recovery. Lots of hand holding and talking the patient through it. She said, yeah, if this is a difference between me losing a flap and salvaging it, go for it. So we opened up the lateral extension on the breast from the mastectomy and also the delta pectoral groove. And I found that the cephalic vein was in spasm over 4 centimeters. So I gently teased with my loops the vein apart, lots of papaverin, undid the kink. And I just wrote in the notes, not for return to theatre. I definitely no return. She's not going back a 5th time. Leeches only. Aim for removal on Friday. And this was on a Wednesday. And to our surprise, over the next couple of days, the flap didn't turn a hair, and she was discharged eventually on day 6. So unfortunately, this is the scar that we ended up leaving her on the arm. The cephalic vein was really small and went into spasm when we were raising it. Normally, this is how I would do my cephalic vein harvest, using an Alfrix retractor, now in the modern era lighted retractor. But this was her at 2 months, and this was her after completion. So yeah, I aged a lot and learnt a lot in this with this case. I'll stop sharing now.
Martin, a fantastic, as you say, victory snatched from the definite jaws of defeat there. And just tell me, I'm interested under local. How did you? Because you presumably opened the top where your periareolar scar was, and then there's no scar down the middle. So you must have been. So it must have been quite difficult to get access.
So we tend to do a lateral extension on the periareolar scar. So
okay. You could just
yeah,
open it up. Yeah.
with 2 Langenbecks and Adam with his head torch on. We were able to, there wasn't even a microscope available. And it was amazing how quickly it pinked up once we got rid of that spasm and out the king. But,
one of those double twists that can happen with that. Yeah.
I kind of think this is, almost where girth came in. I should have got it right first time and not done anything with that patulous vein. It was patulous for a reason. And, maybe if we'd just done the proper operation at the second, when we went back, then we wouldn't have, returned to theatre twice and then one in recovery. But yeah, I learned a lot. You have to surround yourself with good people that are better than you. Roger Smith was always saying, appoint someone better than you, then your unit will grow. And I think we've done that with Adam. And I stored that day in my memory bank, ready for the interview about 6 years later, I think so. So there we go.
I've got a question for the both of you. I just, a really dramatic case, but there's nothing like a salvage that actually works. Can you just talk us through the kind of emotions you went through? Because that must have been hugely tiring, exhausting emotionally, and then the kind of euphoria afterwards when it did work.
Yeah, those people who know me, I kind of, I do like adrenaline. I do like snowboarding, skiing, and motorbike, little sports car. And in fact, actually, as an aside, my little Lotus goes to a place called Lakeside Engineering to get serviced. And the guy said, sorry, what's your name? So I said, Martin Jones. And he said, where do you live? And I said, East Grinstead. He said, you're not that plastic surgeon, are you? He said, how do you know that? He said, my next door neighbour has had an operation down at Queen Vic, and she was his next door neighbour. So it was very weird. So I think the highs and lows are massive in microsurgery, and I think the most important thing is putting the patient at the centre of it. I was only able to do this because she said, "Come on, keep trying." I haven't invested this much time and energy herself into having an immediate reconstruction and all it entails to give up now. The anaesthetist, was very, on board and said, look, she's okay to have another GA, third GA. And you need a 5th gear, a 6th gear, and a 7th gear for microsurgery. You have to dig deep. You have to have supportive family. You have to have, supportive juniors, and you're a team, and you're only as good as the weakest link.
Mike?
I've just got a small point because just a little thing that I do when I do a cephalic turn down is that because I think those long venous pedicles can have the double twist, where you twist this way and this way, and so it then gets stuck and it can't really untwist. So I always put a clamp up here, so that it gets really venously engorged when you're fiddling with it, so that it hopefully doesn't get that double twist when you're insetting it. And then only once it's sort of in and done, then I take the clamp off up here, if you see what I mean, because I think if it's turgid, it's less likely to do that double twist, So and that's a little thing that I kind of do now. I think it's because I had something similar, looked at it and thankfully not gone out of theatres and thought, hang on, that's double twisted, so let's clamp it, so just a little tip.
Both of you just sum up what advice you would give to a surgeon going in to salvage a flap in terms of psychological preparation.
I think from my point of view, it's doable. You just got to find out the reason why it's not working. And I think again, John Pereira said to me, always look at the pedicle. You've got to look at the anastomosis. Don't go in and think, okay, well, there's a bleed on the underside of the mastectomy flap. There it is. That's the reason why I've got a hematoma. It could be a twist in your vein. It could be propagated proximal to the venous coupler, underneath the rib almost. So the reason why you've got a bleed is probably because the outflow, when the blood pressure comes up, is not good enough. So it just oozes out through the flap. So you've got to identify a reason for the problem that you're in, and then it can be quite easy to fix if you know what's going on. The other thing is I tend to have an order. I've done maybe 13 cephalic turndowns and over 1,000 breast reconstruction flaps now. So I don't use it often. I have had also a woman who had pre-existing lymphedema, and I made her lymphedema worse by doing a cephalic turndown. So I don't do them lightly. And I would always want to do a interposition vein graft onto the thoracodorsal if it was available. That'd be my preference. But your other thing is it takes 5 minutes to preserve a bit of length of your superficial SIEV. They're your lifelines. And if you can orientate the flap so that they are in the upper outer quadrant of your reconstruction, so then it's easier to get a cephalic turn down or onto your thoracodorsal if you need it.
Great. We should move on to the second case, please.
Sure. So the second case is again, this is not something that's really gone badly for me, but it's something that's going to happen to those of you that are watching this who are a little bit younger than Martin and I, doing breast reconstruction. So let's go. So so the next thing I wanted to let's just move that up. So so I've kept these patients, by the way, have all given their consent for education and trainings, but not for any other dissemination or anything like this sort of wider up. But so this is obviously for education training. But this is a lady, and I included the bottom part of her face just to let you know that we're now dealing with a patient who's in her mid-70s, and she'd got as you can see, she's had an implant-based reconstruction, been very happy with that for many years, but comes back to me really. With the I hadn't done the primary reconstruction, but came to see me, and we obviously, thankfully, she was relatively fit. She had quite a few other comorbidities, but we had to do something, and I felt that if we just removed the implant, she didn't really want to have nothing. She didn't want to have too much. I didn't think she was going to be well enough, in fact, to have a DF flap. So we tried to keep things to a minimum, and I just put a latissimus dorsi around there, so she's still got a bit of cleavage, and I think she was very happy with that, and she sailed through that operation no problem. She had quite a big abdomen. I think it would have been an awful lot for her to do, and so and the other case, this is a lady, again, a similar age, in her mid 70s, who had exactly the same thing, an implant-based reconstruction that had been in for many years after an immediate reconstruction that was beginning to harden and become a problem. And again, we took that out, and we put a DEP in. And the reason why I thought I'd bring this up in this meeting in terms of challenging cases is because this is, I think, the shape of things to come to a large degree. I think there's an awful lot of people whose implants are going in today will start to cause problems when I've retired, and they will be a little bit older, and they will also be used to living life, with a bust, and won't want to go back to a mastectomy, I should imagine, at that stage. When I started 30 years ago in the hospital I trained in, Aberdeen Royal Infirmary, you had to be under 65 to get to ITU. And now, over half of patients in ITU are over 65. So we've seen, medicine over the last 30 years has definitely, increased. Elderly people have got fitter, medicine's got safer, so we can do these bigger operations in slightly older patients. But, it's more difficult because if you're 80 years and older, once you get to ITU, you're slightly more frail. So if you go to ITU, you're, as you can see from these figures, your 1 year survival, if you're over 80, 1 year survival is 42%, and 2 year survival is 36%. So if you do have a problem with your reconstruction or your health, or we cause a problem in our surgery and everything else, you're dealing with a much more labile population of patients, i.e. you can cause problems. But I show this picture because this is a lady, again, in her 70s, and she's had a DEP flap, and when she first came after I think she had a house in I think it was West Indies, or it might have been Portugal. I can't quite remember where. She first came to see me. She'd got her old bikini where perhaps there was a little bit more tummy, and the tummy was a bit bigger, and you could see from the bikini line that it was a fairly generous bikini. But when she came to see me a year later, I noticed the bikini line had dropped a lot, and she now had a much skimpier bikini. And the point I'm making here is that she's in her mid-70s. She's actually fit, healthy, really enjoying her life. And I was joking to the guys before we started this webinar that I want to be like that when I'm 75. I want to be wearing my Speedos. I'm not sure anybody else wants to see me by Speedos, but I want to be doing that and living a full life. And I think a lot of our patients do this. So I think to those of you, in the earlier part of your careers, where I've seen that 30 years of progress that I showed at the first bit, you're going to see, I think, a lot more challenges and managing, patients in a slightly old age bracket who are a little bit more friable. The vessels are a little bit more friable. The operations are a little bit more technically difficult, I find, in some cases. You've got to be uber careful. So your job is actually a little bit harder than doing this in a 40-year-old or so. And so that's really what I wanted to share as my next sort of case. I don't know what you think about that as a concept, Martin.
I do think cases are getting more complex. I think I long for the day of a simple delayed DIEP, but we are getting patients that are requesting DIEPs into their 70s. So I think the eldest I've done is 78. I refused her at 75, put implants in, and then she came back 2 years later, so we'd just get on and do the proper operation. I hate these implants. So I think age is just a number, but I think the complexity is the problems we're having with implants that are coming back. Deconstructing reconstructions is probably about 15 to 20% of my cases now, and it's usually bipedical DIEPs or two tugs or two dugs or lugs into one breast. So it's getting more complicated, or maybe I'm getting worse at it. You'll find out in a minute.
Yeah, no, I agree.
So Martin, do you want to share your second case, please?
I will do. So let's just advance on to the next one. So this woman was referred back in 2020. She had initially a left-sided wide local excision and adjuvant radiotherapy, and then unfortunately a recurrence 5 years later. And the MBT was suggested a completion mastectomy as it was multifocal grade 3 at the time. I saw her in 2020 with a request for a delayed DIEP, and I thought she should actually do quite well for a bipedical and possibly an uplift on the right-hand side. She had problems with her right kidney. She had renal calculi that meant that she only had multiple urinary tract infections, and she only had 20% of her right kidney function. So therefore, we couldn't do an angiogram. We just had to do a straight MRI, which showed there was a real paucity of vessels. Now, if it's a CT scan, they're there. I feel they are there. But if you have an MRA or an MRI and they're not there, they could be there, if that makes sense, because the slices are thicker on the MRA. And so I brought her back to outpatients and scanned her abdomen with a Doppler, and I couldn't hear anything. Then transpired that she had cosmetic liposuction in the past. There's a couple of papers, one including from Andy Mellington at our unit, showing that you actually can do DIEPs in liposuction. We've got 5 cases where we've done it, but this woman had nothing on her abdomen. So I then consented a counsellor for bilateral tugs or lugs or dugs, depending on where the fat was, into one breast. And I've done about 150 tugs now, I think, and probably about 20, 25, 2 into 1. So they can be quite tricky, and you just have to I tend to take out the fourth rib because I know that then you're more likely to have 2 vena comitants or 2 IMVs to put in. And I want to go antegrade on the vein. So this is what we did. I did it with another colleague. It took about 7 hours. We were kind of finished raising the flaps by about 11:30, but then the micro was pretty difficult. We had to redo one artery. It clotted off. And that was the right lug that was the lower flap was antegrade artery, antegrade vein, and the antegrade artery clotted off. So we redid that and it worked. All was well, got it back to recovery about 4 in the afternoon. There's about 3-1 mismatch. That's the problem with these vessels. I thought I was going to get a call overnight. I don't sleep very well on a Tuesday evening. That's not because I snore. I do, and I keep on getting woken up because of that with an elbow. But this, when it's micro, I don't tend to sleep that well. But I woke up when the alarm went off, and I was doing trauma that week as well. So I went straight to the trauma ward round, got a text from the micro fellow, all was well. Popped down to see her, and a sixth sense said there's something about to happen. But I got called back from a trauma case at around about 1 o'clock. Took her back to theatre, and both arteries were clotted off. Simon Mackey was on call for the evening, and he'd finished his case, so he popped in, and then Adam Blackburn swing past. So this woman had 3 consultants working on her, and I redid one of the anastomosis. This was the upper flap this time. The retrograde artery had about a 2 centimeter clot that I pulled out, hepsaled, redid, and it flowed straight away. There was flow into the flap. None of the veins had clotted off, flow into the flap. And then that was on Doppler and Pulsar. And when we deepthelialized a bit further, it bled. So we detached the lower flap, that's the antegrade artery, antegrade vein, and we ultraplased it. So we got a protocol for ultraplays, which is on the screen as well. Put 2 milligrams of ultraplays. We also gave her 5,000 IV of HEP when we first got in, and good flow, and there wasn't any oozing. And I put it on the note, only go back for a hematoma. I finished at 5:30, raced over to do a private clinic, just sat down, got a call for a hematoma. She had 200 mils in her drain and was taken back. So Simon Mackey was on call, kindly stayed and took her back. I managed to get there by 8 o'clock, and there was just a bit of generalized ooze that we stopped and put 1 stitch back into the artery, and the flaps were bleeding and pulsating, but very, very bruised. They looked really frightened. So I thought, rather than frighten the patient and the ward staff, I only wanted to go back for hematoma. I don't think she could have taken a further trip to theatre so soon. So I ended up covering that up with Mike Brown micropore tape. All was well the next day, but the following day, so day 3, this was now the Friday. This was Thursday. That the kidney function looked good. She's got 1 kidney, because what I didn't tell you was the delays to get to theatre were not only COVID from 2020, but also she had a right laparoscopic nephrectomy as well. But on the Friday, so it's the end of my trauma week, I nearly fell off my perch. I saw the CK had risen up to 2,271. Her EGFR has started deteriorating. Her creatinine was up. So her remaining kidney was really not looking good. So, took down the tape, and to my surprise, at that point, I knew we had 2 dead flaps. So I stayed that night, and I took her back to theatre, and I removed both flaps. And this is the site that I saw. And we've got FLIR cameras in the breast reconstruction theatres, and they're really good, actually. And you can look at, I look at mastectomy flaps, I look at flaps on the abdomen with a FLIR camera. They're about 250 quid. And they just look at the temperature and infrared monitoring. So I was able to close the skin, and she was discharged at 6 days post-operatively. But I think there were lots of learning points. This was just before I went away on a family holiday on the Tuesday. She was in till Monday. I was meant to be off by the Saturday preceding, but I went to see her every day. I knew that it wasn't going to go well on the Thursday. And I think you have to put yourself in the patient's situation. It's a lot worse for them than it is for me. Even though this is the second and third flap I've lost as a consultant, and I think you start feeling sorry for I felt really sorry for my colleagues, actually, because we've got a failure rate of less than 0.5% at Queen Vic as a group, and I know I've significantly increased that for them this year. And what am I going to do for this poor woman now? So intuitively, surgeons love to blame other things than themselves. So, I'm waiting for that thrombophilia screen to come back, and I really hope it's going to show a protein S and protein C, but it doesn't change the outcome. It is a devastating result for that poor woman. So you have to almost become their friend and see them a lot more than you would normally, and walk them through this situation and make the best of it. So I'll be seeing her in a couple of weeks with the results of the thrombophilia screen. We're going to probably do a reduction on the right-hand side, fat transfer to the left, and that's possibly going to be it. But yeah, I at the time thought, right, this is not a great operation. I've done 25 of them, 24 of them have worked. I'm not going to do another one, and blow me down, I got off a holiday. The first operation I did was an immediate bilateral lug into one breast that was the next on the list. So Mike does a brilliant talk, if you've seen it, on surgeons and hubris. That was playing in my mind when I was sipping my gin and tonic on my holiday, thinking, crikey, is this me going over the hill? So yeah, you do a lot of soul searching, but I think you have to help a lot of people most of the time. That's what we're trained for. So yeah, difficult case.
Thank you very much for sharing that. I think that's massively valuable for you to speak so openly about what's clearly a very difficult case to work through. Could you say, how would you advise another surgeon who has been through a similar loss in moving forward, and how you cope psychologically having gone through that?
I think talking is really good. Sharing, actually, I think if you ask enough people, there always will be one or two cases that you think, crikey, that will really live with me. That will formulate how I go forward, how I view my own ability, and talking is really, really good. So I'm extremely lucky. We've got 8 other consultants. We talk about these things all the time. We have a monthly meeting, and it's incredible to actually have a problem with a flap and to be surrounded by 3 other consultants willing it to work and trying to think of everything they can do to make it work. And I think, surround yourself with better people than you. If you're in a position to appoint someone into a unit, make sure that you appoint someone better than you, because the unit will be better and grow. That's the main thing.
Yeah, and I think the other thing to do is like you, Martin, I've had two losses over the 20 years now, and the first was just a simple error. We had a big case. It was probably a 2 kilogram flap. Obviously, we weren't going to use all of that, and we'd done one side, and then everything was freed on the other side, and it folded back itself, and there was just one perforator that I clipped, and that was the only thing that folded back itself. And between my registrar and I, we cut the pedicle, but no one was holding the flap. The flap started to fall towards me, and there was I'd saved a nice arch, a nerve at least, and the 3 perforators just went ting ting ting, and just avulsed. And this is the thing that really annoys me. I sort of thought, no, don't panic, think about it. And I said, okay, fine. Went into the fat, dug out the avulsed artery and vein, and did then a series of 6 tiny little anastomosis to redo them. Or I think I only did 2 in the end, so it's 4. And then and blow me if the thing didn't start to flow. So I thought that's fine. And as you say, got my dose of hubris. Thought, you know, I'm bloody marvelous, etc., etc. Went in on Thursday, absolutely fine. Went in on Friday. I was just going to see my bro who lives in France. So I thought Friday, you know, I think I'm safe. I'm going to go. And then of course I'm in France and my phone goes at 10, you know, and I see it's my reg and it says it's gone. Oh my gosh. And I said, well, can you take it back? If it's the big artery, you know, it's the main thing, then can you try and repair it? But if it's the little ones that, you know, are literally in the fat, it's gone. And it was little ones, so it went. But the thing that really bugs me about that case is obviously we've changed our practice. We always put a couple of clips on. So we've, you know, it's a bit like when you go in that Go Ape, you know, you've always got to have 2 clips on. We've always got to have 1 clip somewhere on the thing, you know, at least 2 clips, you know. So that's the sort of standard for us. So we have learned from that. But the thing that really bugged me was that what I should have done is not gone searching into the fat, the valve bit. I just cut a nice big perforator on the other side, and it had been clipped, so I could have, you know, easily dissected that, and actually should have put the pedicle, you know, which hadn't, you know, cut the pedicle where the perforators came, so that it was undamaged pedicle, put it onto the other side, which would have been an undamaged thing, and it would have taken me half the time, and it would have been safe. And I'm just so annoyed I didn't think about it. Although the guy I was with, my registrar I was with, is probably the most intelligent man I know, and so actually he didn't think of it either. So I've got at least some respect. That's really annoying. That's really annoying. And I got to say the other thing, my other case was a bit similar to your venous, the slow venous death, and I perhaps should have done a venous turn down. I chose to do a venous turn down too late, very similar to you in the case that you described. You know, it was a little bit venous, and I thought, oh, that'll be okay. And then the next day it wasn't. So I went in and I fiddled, just like you did. I fiddled with the deep system on the Thursday, and then I thought it would be okay. And because we had taken off a little bit of tissue and had bled in theatres, it all looked too bad. And it wasn't the venous outflow, the mismatch wasn't too bad, you know, so it didn't like go really, really blue. It was a slow one. You came back 4 hours later, and, oh, you know, so of course, come back on Friday, take it back to theatre. But by now, the superficial vein was just solid as a rock. I couldn't really do the venous turn down, and it was game over for that. But I reflect that was the week that my mum had just gone into she had dementia, sadly, and we'd put her that week she lived 2 doors down from us for 3 years, and we'd managed it, and then we'd reached that point where we perhaps, you know, we felt that she was going to have to go home. And I wanted to sort of finish the case on the Wednesday and go and see my mum and everything. So, you know, it was one of those ones where my brain, you know, I wasn't really thinking clearly, and that's, you know, that you know, and I know, James, you talk about this performance. You know, we forget that if we're just taking a mole out, we can do that when our brain's thinking of other things. You know, I liken it to some operations are a bit like sort of driving to Heathrow. You could get Lewis Hamilton or Nick, who's the taxi driver we normally use, to drive to Heathrow, and you wouldn't know the difference between the 2 drivers. But if we then went to Silverstone, the difference between Nick and Lewis Hamilton would be vastly and immediately apparent. And I think some of our operations, we've got to work out, when are we driving to Heathrow, in which case, fine, and when are we actually on Silverstone? And now we've got to be, you know, we're actually now, this is the big stuff, and we've got to be singing on all, you know, on all quarters. And we've got to also sort of admit to ourselves, look, am I ready for this? And that, I agree, I think that's when your colleagues really come in. Really important. Yeah,
that's a really good point. I wondered, you know, one of the things I take from your stories is, first of all, never do a flap just before you go on holiday. And the second thing, the other, seriously, one of the kind of difficult judgments to make is how far do you push it when you're trying to salvage a flap? Because as Martin's first case illustrated, you can go to, you know, the 3rd operation and just go for it, and you can save it. But then the second time, you know, sometimes it can be a futile exercise, and making that judgment is difficult. Can you speak to that?
from my point of view, I think you've got to individualize it. You've got to take the patient as a whole rather than a personal tragedy or triumph in terms of a flap. If they're not very well, if they're having problems like the second patient with a kidney, you have to treat them as a human being. And because it hasn't gone well for you as a surgeon, doesn't mean you should literally flog it. So everything comes into discussion. You chat to the patients, to the relatives, to the anaesthetist. I remember that first time. We've done a couple of 4 flappers as well at Queen Vic, and as a test case, I did a woman who had a delayed reconstruction, where I ended up doing. That's right. She had a mastectomy on the right-hand side, and then she found out she had the BRCA gene. So she was referred to me for a risk-reducing mastectomy on the left-hand side that was done by the breast surgeon, and immediate reconstruction, which I used 2 tugs into one breast. And then we're going to come back and do a bipedical DIEP on the right-hand side as a delay. So it's 4 flaps, basically, but over 2 episodes. Now, interestingly, I should have presented her as well. I've got many of them. I was called about 2 a.m. with her with her upper flap that was congested. Interestingly, the registrar couldn't be raised. It was the SHO that called me. Got her back to theatre. The reg came in and actually held the lower flap. The 2 flaps were delivered, and I think went to sleep for a moment and rocked back a little bit, and the lower flap was avulsed. So at one point, at 4 a.m, it was like a Hamlet moment. There were 2 flaps with only 1 vessel attached, and yeah, it was interesting. So I thought, where's that blood coming from? And I found out where it's coming from. So we re-anastomosed it, but the point of the story is that woman didn't want to go back to theatre at 2 a.m. She said, no, I know it's not going to work, but I don't want you to take me back. And I said, look, I know I can save this. She said, no, I'm scared of going back. And I let her have 15 minutes to think about it, and said, look, this is what I plan to do. I will possibly have to use the cephalic turn down, and that's one of the 12 that I've done. And it took her about 2 years to come back and have a delayed reconstruction on the right-hand side to be symmetrical. And the first thing she said to me when she came in, said, I bet you didn't think you were going to see me coming back. And I said, no, I didn't. But she's now got a fairly symmetrical pair of breasts, but went through the mill to get it. So I don't think we should underestimate what we put patients through.
No, but I think that also tells us that we shouldn't underestimate the value of what we do to, and I think that's one of the problems with breast reconstruction, because we in terms of healthcare measurement, if you've got a mastectomy, you can do all the normal things of healthcare measurement. You can wash and dress yourself, you can feed yourself, you can get a job, you can have a loving relationship. Do you know what I mean? And so the value to that person is so individual and also emotionally based. So it's going to be different from person. You meet patients, listen, I'm fine with a mastectomy. So and that value, and of course health economists hate having this variation. And hate having this measurement. Hips are easy. You can walk 50 yards or you can't, or whatever it is. And what we do is because it's so entwined with emotions, it's very difficult to measure. So I think we are under. It behoves us to cases like what you've said. You illustrate a lady who's been through an awful lot and would have been very, very frightened coming back to you, and yet she was still driven by this desire to have a breast on her other side to come and see you. And that's a pretty powerful drive. And it's that people talk of, I can't remember whose eponymous name we give to that hierarchy of needs, when everything else is fine, but you don't have a breast, and that's what drives you. And it's powerful what we do.
Thank you both very much. We really appreciate your honesty and courage to talk about your cases. So we're going to round up the evening. Perhaps I can just ask one more question to Mike. How do you think that affected your relationship with that registrar that you were jointly holding that flap that slipped?
Well, I mean, I think this is the other thing. I mean, we were a team working together, and it hasn't affected our relationship. I get on with him very well. I won't tell you. Won't tell you that I share an office with him, because that might mean you might be able to identify who it is. But but and it was a team. It wasn't him. It would be. And actually, we're both trying to do our best, etc. It's I think more challenging is the registrar sort of falling asleep and pulling the flat with him. That would be. I think that would be more challenging.
You could have blamed him, of course. So that shows nobility on your part. Many consultant would have blamed the registrar.
Yeah, no, and of course, no. I mean, that's crazy, because that was it wasn't. That was one of these things that happen in life, and we just had to get on and deal with it. And then, as you said, we learned, so we have 2 clips on at all times.
Thank you both very much. All right, so we are going to wrap up the evening. Many thanks indeed to Martin and Mike for sharing your thoughts about your memorable cases.